Okay, good morning. All right, so we left off, we talked about type 1, type 2, pre-diabetes, metabolic syndrome, lots of slides, lots of information, lots of test question rates. This is the biggest one. We're going to wrap up part 1, and we should be able to finish part 2 okay? So the dawn phenomenon and emoji effect is just the last piece. I believe you got introduced to this topic in FAR. So, I don't have like a really great heat or trick to remembering these, but this would be maybe a good test question. I'll go over it more with the review, but when we do the review. But comparing the difference between these are important. But essentially, in both situation or both condition, these patients will have a high blood sugars in the morning, and then you're trying to figure out why. Is it and there's these two phenomena. Dawn phenomenon is more common, and up to 75% of people with type 1 diabetes will have that. But again, you have to investigate, and the best way to do that is to get a blood glucose or blood sugar early in the morning, 2 to 3 a.m. Okay? And that's going to point to the dawn phenomenon or SIDO. So dawn, when you check that blood glucose at 2 to 3 a.m. or 2 to 5 a.m. really, the blood glucose is going to be high. You're getting, essentially it's due to hormones, whether it's growth hormone, a little bit of cortisol, starting to increase. And then there's some insensitivity that happens with some patients too. But dawn, you're getting that early morning blood glucose, it's just getting high way too early. Okay? And so if my glucose is higher than it's supposed to be at 2 or 3 in the morning, how should I adjust my insulin before I go to bed to fix the problem? Increase, right? When I increase the insulin from the slide to counteract that. And again, but both Samoji and dawn are high in the morning. So let's look at Samoji. When I check the glucose, it's actually nocturnal hypoglycemia. So your blood glucose drops in the middle of the morning, but we have these, we have other hormones and other backup things in the body to help maintain homeostasis. So catecholamines are going to go up, maybe a little growth hormone, but usually it's epinephrine and maybe a little growth hormone that gets released to help counteract that hypoglycemia. So it's like your body's reacting to the dip in blood glucose, okay? Is that all? Essentially, that's what this is. Yeah. Treatment would be the opposite, right? So if we're going hypo in the morning, we're going to modify our insulin dose too, right? By reducing it. Make sense? Here's a table for visual learners. Again, with dawn, they're hyper in the middle of the morning, and when they stay hyper, so it's like the body's waking up a little too early. With Samoji, it's low, so low, Samoji, I don't know. If you guys have good tricks, share them with the class, share them with me. That's it for part 1. Any questions on anything we talked about doing that, or if you have them later, let me know. Okay, so this is part 2. I like this one. It's more pathology and complications, and it's yeah, I like it. So hopefully when I like something, I go a little too fast. So sorry. All right, so it's broken up. It's all about complications. Acute versus chronic. Okay, so we're going to go through each section of these, and this is again to reinforce that we need to treat our diabetics and be aggressive with that. They need a lot of patient education, and yeah, to prevent or prevent them entirely or prevent the progression of such disease. Okay, so acute complications, hypoglycemia. This is the most common complication conversation you'll have with patients who are on insulin. So our type 1 diabetics, right? And some of our type 2 potentially are at risk. Symptoms of hypoglycemia begin when glucose goes less than 60. Now that's not like, that's what the research says, and that's not a hard number. So I'm not gonna make you, I might give you the number to help you get to an answer, but I don't need you to necessarily memorize 60 and then the next few numbers, okay? But it's gonna vary for everyone. So there's some of you who might have a blood glucose of 58 right now and feel just fine, right? Because you're not diabetic. But the opposite is true. If you have a patient who's diabetic and usually their blood sugar is a nice 140, they might start to feel hypoglycemia before 60, okay? So that's but for the tests, for not real life, symptoms begin at 60, but that varies. You have adrenergic and neuroglycopenic responses, okay? So we're going to go through each one. Adrenergic is what happens first. It's between the 54 to 60, and we're going to have tachycardia, palpitations, sweating, maybe feel a little restless, and definitely you're going to have nausea and hunger. So you have your sympathetic and parasympathetic responses, right? It's not quite as simple as feeling hangry, but it's kind of, you're on edge, you're grumpy, you don't feel good. Kids might not report this to you, right? Remember, most type 1 diabetics are diagnosed with kids. You can understand that a kid might push through these symptoms. So kids are just different, guys. They go, they compensate, and then they crash. Beta blockers. We use beta blockers for hypertension. How many of our diabetics might have high blood pressure? A lot of the adults, right? Especially our type 2, but type 1s as adults, they can get hypertension for sure. So beta blockers mask these symptoms. So a lot of education to our patients, right? And probably our patients' families, so they can catch this earlier. And remember, this is an acute condition that can have really bad outcomes. And then as the blood glucose isn't, or the lowering blood glucose isn't addressed, and it falls even lower to around 50, then we have our neuroglycopenic impacts. So confusion affects their vision, they're tired, they have a headache. And this is why what really needs sugar? And if it doesn't get sugar, yeah, our brain, our CNS, the brain likes sugar, it's not getting it, right? Hypoglycemic, so then it continues and you have loss of consciousness or seizure. There is an adaptation that happens, especially with type 1 diabetics, where that autonomic warning, so the parasympathetic and sympathetic warnings here, you get essentially adapted, and so you don't have that early warning coming, and so you're gonna, when you feel it, you're gonna be really have the headache, difficulty speaking, all of that stuff. So you need to educate people on that. If you have a patient, it's not on the test, but if you have a patient who's struggling with this hypoglycemic unawareness or this adaptation to the low blood glucose, what you would do is you would modify their insulin so they're hyperglycemic for a little while, for a few weeks, and then that helps reset their symptoms. Why is it important to educate patients' families too? What do you think? There's 2 reasons. Yeah, the adaptation, and these are kids. Again, a lot of times these are kids. I don't know if I really hit this home yesterday, but I did with the age. What's the average age of someone who's diagnosed with type 1 diabetes? 10 to 14, right? 10 to 14. But infants can get this too. Can you imagine a 3-year-old with type 1 diabetes? So if you have either friends or families or future patients that have a kid with type 1 diabetes, how do you think that parent feels when they leave the house? And their kid leaves the house scared, right? There's nervous system anxiety associated with this. So, essentially, if your kid has type 1 diabetes, it's like you, as I guess a parent, also have type 1 because you're worried about it, you're focused on their pump, all of that stuff, their glucose, all these things. It's really hard to give a 2-year-old a pump versus a 14-year-old. But what 14-year-olds, they're not always as mature, and they want to eat what their friends do, they want to eat junk food, all of that stuff. So again, type 1 diabetes is a really big deal. Okay. Behavioral things that can cause people to go hypoglycemic. They give too much insulin, usually accidentally. Maybe like, I think I'm going to eat this many carbs, so I give myself a bolus, I get interrupted, I don't eat, or I don't know, something interrupts my lunch, and then my insulin's too high. Drinking excess alcohol, especially on an empty stomach, we talked about that. If I'm exercising way too much and not supplementing with sugar or food, or use stack insulin. A lot of teenagers might do that because, again, they're like, oh, my friends were going to Dairy Queen, or I don't know, we're gonna go out, and so they might stack insulin, and that gets them into trouble, anticipating the junk food or things like that. Okay, that's really it for this, because we'll talk about complications. Okay, best treatment is preventing this, right? Education, having them carry juice or glucose tablets. And then teaching them the awareness of hypoglycemia, and then if that fails, they can have a metal or bracelet tattoo, something that helps the paramedics, bystanders know that they have type 1 diabetes and basically just need some sugar. Alright, medication, the last thing is just like other things like liver, kidney disease, other things can interfere with picking up on hypoglycemia. That's not a huge deal. All right, so I have a patient who's starting to feel those autonomic symptoms, right? Some nausea, nausea, stomach ache, vomiting, they're hangry-ish, palpitations. We just give them 15 grams of carbohydrates, okay? And we wait 15 minutes. It's like a 15-minute rule. I feel like that's the longest 15 minutes if you have a kiddo. But you give them these are just examples of 15 grams of carbohydrates. Has anybody had glucose tablets before? They come, at least in my memory, they come like in a square or a circle, like the two kind of like Tums or what else? Or Mentos, but bigger. And they're really chalky. And they taste okay. Some flavors are gross, some flavors are better. But diabetics will have those. The juice works well. Obviously, we don't want sugar-free candies, right? We want the glucose in there. Raisins, who would have thought there's a purpose for those little cups? There are little boxes of raisins out there. That is a lot of sugar. It's cranberries too. All right, so those are mild. What do you think we need to do for more moderate or severe patients like getting confused, maybe going towards unconsciousness? What should we do then? Any guesses? Do you give them anything? Do we inject them with glucose? Okay. No, we're going to do glucagon kits, okay? So you have these little kits, and everyone who's a type 1 diabetic should have this. And this is when they're at home. At the hospital, we have a few options. That's the next slide. So we're going to give them a glucagon kit. The biggest thing to tell patients and family with this is that you have to make it's not pre-filled. So that tube, you have to, it's a powder, and you have to, there's a pre-filled syringe, so you have to take the pre-filled syringe, inject it into the powder, and then draw it up, okay? So it's not as easy as that, okay? But it's important to have at home. So you have your glucagon kit, and then if they're fortunate enough to be in the ER, we can give them IV glucose, we can give them glucagon as well. You can also do honey. You can put honey in the buccal mucosa. That can help as well. Any questions on hypoglycemia? Keys to prevent it. You know all the things to put your patients down, and you know what to do about it. Some raisins and some glucose. Any questions on hypoglycemia? When I was at that diabetes camp, the kids, they would do all these exercising and stuff, and they would be, I don't know, what's that blob, and they would jump on the blob and then fall into the lake, right? So they do that, they're swimming all day, and they would act just fine. And then all of a sudden they wouldn't complain of like headache or anything, they would just maybe sit down or something. And so again, the kids, you just have to almost watch them a little bit closer. But as they get older, they pick up on when they're low and they'll check things. But pumps are a game changer for these kiddos, okay? All right. And DKA. So, you guys have heard about DKA, I'm sure, in pathophysiology. Let's break down the names. So, acute, got it, complications. But, so diabetic, what do we, when you hear the word diabetic, what do you immediately think? Sugar, right? High blood sugar. So this person has high blood glucose. Keto, what do we think there? Ketones. So this person has blood in their ketones in their blood, as well as their urine. Okay, so serum ketones, and then acidosis, right? So what does that tell me? Yeah, pH is high or low?
Low.
Low, right? This is specifically a metabolic acidosis, okay? So when we go to treatment, I have a few slides on treatment, and the order is really important with this, but these people, their blood glucose is really high, so it's around 250 or higher, and so some people, especially new to medicine, might want to be like, oh, I gotta fix that sugar, it's so high. But it's actually the dehydration and the electrolyte issue that you need to fix first, and then give them a little insulin and all of that. So it's a very gradual treatment. So if you overtreat it, you can have some consequences. So again, yes, the high glucose is important, and we need to fix that. But there's other things we need to do first. Okay? If we get distracted by the high glucose, we can really hurt our patient. So incidence. 5 to 8 episodes out of 1,000 diabetics annually. So it's more common than HHS, so we'll talk about next. Primarily in type 1, but this can happen in your type 2, especially if they had like an infection or trauma, some precipitating issue that caused it. So again, most likely type 1, but it can happen in both. And it can be that initial presentation for a lot of our type 1 diabetics. We do a lot better with this, right? Because we have insulin now since the 1920s. We've been using this, so outcome is pretty good. Obviously, better in younger patients than older for various reasons. Elderly, they run on to do as well. So, pathophysiology. So I could spend a lot of time talking about this, but I'm going to keep it really simple because you already have pathophys. If you're at every reason to get confused when you go to labs or treatment, fall back on the pathophysiology, okay? Because you can use that to help you understand things. But essentially, the main problem is what in type 1 diabetic? They don't have insulin, right? So we have insufficient insulin as the catalyst for this problem. So when I don't have insulin, what does my glucose in my blood do? It's up, right? And we need, insulin helps get that glucose into the tissues. The tissues want the glucose. All right, so that's not happening. So the body reacts, right? And the liver is kind of come to the rescue and be like, I got it, I'll make some more glucose. Because all the body sees is that the tissue needs glucose and they're not getting it. So we have gluconeogenesis. So we're trying to get those tissues energy. And so we create more glucose, and we also break down and create fatty acids for our energy, okay? And then those fatty acids get oxidized and they create ketones, all right? And ketones in the bloodstream, that's a huge problem, and then we get acidosis, all right? So end result, excess glucose, excess ketones, okay? Pretty simple. Lots of fun biochem going on, but that's all it really is. Okay. This is just like a breakout of that picture of what we saw. Just make sure I talked about everything right. So we have diminished glucose into the peripheral cells. So then we get ketones in the blood so that we can get energy. Do you guys know the different types of ketones that are created when fatty acids are broken down? So there's the beta hydroxybutyrate and the acetoacetate, which is like acetone, I think. Anyway, so your urine, when you check urine ketones, it's usually the acetoacetone only. So you can do, for blood ketones, you would just do a panel. Or sometimes some labs will only check one or the other. But essentially, just check ketones. But in real world, you need to know the difference when you're in clinic, when you order the lab, okay? And do you know that not everybody can smell acetone? Here, right? And that only like 30% of the people who have DKA will actually have that odor and that breath. It's interesting stuff. Okay. So we talked about the high blood glucose. We talked about the ketones, metabolic acidosis. But the fluid and electrolyte depletion is huge. So as glucose goes up, remember when glucose hits 180, I start peeing it out. So glucose in my urine, so that's dehydrating me. I have all of this. There's a shift, so sodium goes down. There's actually, we'll talk about potassium in a minute, but when you do the blood work, it says that potassium is elevated, but it's actually not. It's depleted too. So there's just like a lot of electrolyte issues and dehydration. Osmolality, remember that? That's that serum concentration. The serum osmolality becomes more concentrated, and so it also goes up. So again, maybe it's a slide later, but again, the potassium, it moves when you're in this acidotic state due to the ketones, because ketones drop off of hydrogen. Sorry, I'm going a little past biochemistry. Okay, so essentially the potassium goes extracellular, and we need to remember that when it comes to treatment. Like honestly, they're likely to be low potassium. Okay. All right. So initial manifestation. So again, I initially present with type 1, and I can present in DKA. Another thing is infection. So I have a bad infection, pneumonia, something significant that causes DKA. Insulin is the issue. I failed to treat and follow my insulin guidance, right? So I have poor compliance with my insulin. Incision, so I think of incision as surgery, some kind of stress to the body like a surgery. Trauma is another one. Intoxication, either from alcohol or illicit drugs. You see all these eyes I'm using, that's what helps. Current teaches it this way, but I think of the 5 or 6 eyes. And then idiopathic or is another option. Okay. So sick day guidelines. So we want to prevent this for educating our type 1 diabetics. And so what we can do is we need to educate them that when they're sick, they still need to stay hydrated and take their insulin. So you guys remember with Addison's, we did sick day protocol with cortisol, right? So this is kind of similar. So when a type 1 diabetic has an illness, you want to have them check their urine ketones. If their urine ketones are high for over 6 hours, they need DBC, okay? Because that's showing that you can have a little bit of ketones and then reset, but in this show, after 6 hours, it's not resetting. You can also use their blood glucose, right? They have a pump, or they have all the stuff to check their glucose. And so if their glucose is over 250 for 6 hours, they need DBC. Okay? So those 6-hour criteria for both. And let's think about this. So if you're a patient and you're sick, say you have a GI bug. All right, so I'm throwing up, I have nausea, throwing up, diarrhea, all of this is a good, like, nice benefit, right? When do I take insulin? I have the basal insulin all day long, right? And when do I do my boluses? When I eat, right? Okay, so I'm throwing up. I'm sick, I'm not eating. So do you get why they would be like, I don't need to take my insulin? So, but when they do that, yes, you're not eating, so you may not need as much of those boluses, but your body still needs insulin. Okay, so that's how an example of how they get that and why it's so important to educate this in the companies. All right, so it can be sudden, but and this is 1 to 2 days. It can be more like it can last over a few weeks too. With polyuria, polydipsia, nausea, vomiting. A lot of times these people have like abdominal pain. Significant abdominal pain too, that comes in. And maybe that abdominal pain, like appendicitis, could be the trigger of DKA too. Only like 10% will progress to a coma because we catch this, they bring them in. Are these patients going to you in your clinic or are they going to the ER? Yeah, I hope so too. Yeah, that's what we're looking at. Yeah. That's why, because I don't work in the ER, I think this is fun, because I don't get to treat this. All right, so signs, they're dehydration, very dehydrated, very dehydrated. The Kussmaul's respiration, do you guys remember what that is? It's this rapid, deep breathing. So you're having these rapid, super deep breathing, but they don't really appear in respiratory distress, per se. They're just breathing. And why are they doing that? They're in this metabolic acidosis. So why am I breathing? Yes, you want to get rid of the carbon dioxide. Yes, you want to breathe that out. It's a compensatory reaction to the metabolic acidosis. The fruity breath or odor from the acetone might be present. For sure, in some patients, hypotension with tachycardia. Why do I have that? So they're dehydrated, right? Or dehydration. Also, it's like most people don't necessarily have shock, but again, you're kind of like this pre-shock person right here. I already mentioned this, abdominal pain, and then they might have hypothermia. There's a link to Kussmaul's if you want to see that. There you go. So, lab findings. I tried to condense this all into one slide. I hope it's not too busy, but it's kind of nice to have it all in one place. So, diabetic ketoacidosis. Hyperglycemia, check. It's going to be over 250. Now, there is a range, and it's not like a hard, fast number in clinic, but for testing, hyperglycemia over 250. Elevated serum ketones. Yep, we got that. It's in the name, right? We know the two types of ketones that exist. And then they have to be in acidosis, okay? So your pH is low, and if you get ABGs and check, you would get the bicarb as well. Glucoseuria and ketonuria, we get that, right? There's glucose spilling into the urine because I'm in this hyperglycemic state, and ketones also spilling in the urine. Those hopefully make a lot of sense. Hyperkalemia, so the potassium may appear high, but again, there's a shift from that potassium from intracellular to extracellular because of the acidotic state, and so it's a huge part of the treatment. They can be hyponatremia because the dehydration and the polyuria, the vomiting, all of that stuff. And then your ion gap is high. Did you guys learn about ion gap in one lab? I think you'll get it in GU. But when the iron gap is high, it indicates metabolic acidosis. This isn't part of a test, but if you're like someone who needs to understand what an iron gap is, so it's essentially the difference between positive charged ions, so your cations, sodium, potassium, and your negatively charged, your bicarb, your chloride, all of those. Okay, so when it's high, it indicates metabolic acidosis. Key factor to DKA. Okay. Just helps with along with that pH. And then you have other enzymes and things that are going to be off. So this is, go ahead, yeah.
Sorry,
no, you're good.
You got the high sugar, you got the ketones. So is the polyuria compensation mechanism, or is it just like, is that our body trying to get it out of my system? So
yes. Yep, you got it spot on. So when our glucose gets to, blood glucose gets to around 180, we start to dump it in the urine naturally, and so it's up to 250, and so it's that. That's one of the reasons. There's multiple, but that's one. And then we're drinking more to try and compensate with that. But yes, you're on it. So there's different criteria, and it's all related to how they present, are they alert or not, and then their pH. Okay. A lot of these patients are managed in the ED for a while, and it's just because of resources in hospitals and things like that. So the moderate DKA actually might be in the ED, not necessarily the ICU. But again, that's just awareness that there's the criteria for it, based on, again, pH and their how they present. All right, so we're going to go into treatment. Any questions on the pathophys, what led the patient here, labs, you guys feel okay? All right, so basics of treatment. They are dehydrated, so we need to give them saline. We need to give them insulin eventually, and we need to I keep talking about that potassium. So those are kind of the three things. We'll go into all of these slide by slide. But at the bottom, it says FYI. It'll say FYI a few times, but monitoring vital signs, how they present in their labs is so important. A lot's happening at the same time. You're getting labs, you're getting IVs, all of that stuff, but you really, once you determine they have DKA, you need to monitor them and make sure what you're doing is working. Because you don't want to have rebound DKA, and you don't want to have cerebral edema and things like that from the treatment, okay? So again, you don't have to know that for the test, but we're continually monitoring these patients. All right, let's go into each one of these things. So first, primary thing is we have a patient with DKA, they come with nausea, vomiting, they have a history of type 1 diabetes, we're gonna get labs, okay? While we're getting labs, we're gonna start fluids. They're really dehydrated. So yes, their blood glucose, we can do a stop glucose at the bedside. Some of those glucometers don't read past a certain level too, so it might just say high, right? So we can know that they have high blood sugar right away, but we need to focus on fluid replacement first, okay? And we need to get labs for these patients. So they're usually deficient by 4 to 5 liters. And again, lack of fluid replacement is really leads to bad outcomes. There's a lot of details in the book about this that you don't need to know. So really, I just want you to do fluids. Don't do them too fast, right? Because we don't want to cause cerebral edema. And yeah. So, any questions on that? So in the bottom block, it says goal serum glucose is 250. So when I give this patient fluids, it's a huge part of treating DKA. And then eventually I'm going to give them insulin next, right? But I don't want their glucose to go down too low too fast. So if I focus only on the glucose and I drop their glucose from 300 to like 100 and I'm shooting for normal, I'm going to cause harm to this patient. Okay, you don't want to drop it too low because first you want to fix the ketoacidosis first, and then later, once the ketoacidosis is first, then you can focus on controlling the sugar. Okay, that's essentially what that means. So if I'm treating this patient with fluids, I'm waiting for my labs, I give them a little insulin, and all of a sudden their glucose drops to like 180, I'm actually going to give them sugar to bring that glucose back up. Because again, it's going to be a slow process. All right, so we get them fluids and I get their labs back. And if their potassium is greater than 3.5, I can go ahead and give them insulin. Now each ER might have a little bit of like the criteria for potassium level might be a little bit different, but for this it's 3.5. So my potassium is at least 3.5 or higher, I am going to go ahead and give them insulin. There's, you can do a bolus and then followed by a drip. When I give you on the test, it's just going to be insulin, okay? But in real life, especially if you're interested in the ER, the data isn't sure, like, is giving them the bolus cause an increased risk for cerebral problems, and do we need to skip it altogether? The data doesn't say it's bad or one's better than the other, but you might see in clinic that they skip the bolus. Again, what is the insulin doing? Why does this person need insulin?
Pushing glucose into muscle.
Yeah, we need to get glucose into that tissue. We don't want to overload it. We don't want to go too fast. And it's actually 0.1 unit per kilogram. It isn't very much insulin. If there's 70 kilogram person, it's only 7 units, right? So we're giving a little bit of insulin. We're fixing that shift. How does that fix the ketoacidosis? So ketones were created. Why? Because the tissue couldn't get glucose. We're giving insulin to get the glucose. So it's helping to gradually fix that ketoacidosis, but it takes time. Okay, the fluids are helping with the electrolytes and dehydration, so that's helping a little bit, and then the insulin is helping as well with both. Okay, now if potassium is less than 3.5, right? Because I'm getting my labs before I give insulin. Then I can't give insulin until I give potassium first. I need to correct the potassium. So let's look at that. So there's a shift. Once I give this patient, so I'm giving them fluids, and then I give them insulin, and that's going to allow glucose to go into the tissues where it needs to. But at the same time, we're having a shift of that potassium that goes intracellular, and then essentially potassium drops. So they're hypokalemic. So you have to give this person potassium before the insulin, okay? Because we're fixing the DKA, but when we fix it, we dump the potassium, okay? All right, so 3.5 is that magic number. And so we're gonna give them the potassium. Once the potassium level is where we want, then we can go ahead and start the insulin. Okay. There's a nice pretty slide at the end. It's nice to understand the reason why we give meds versus just do this. We can use EKGs, right? Because if the potassium tanks, so we're going to see arrhythmias, right? We don't want that. Next one's plus or minus sodium bicarb, right? This person's in metabolic acidosis. Maybe we should give them bicarb. You won't do this unless their pH is less than 7. Some is 6.9. So the pH would guide you, but rarely are you going to do this. This would be like a very severe patient in the ICU. But no, it's plus or minus that it's a potential. But essentially, the patients who get bicarb don't do so well. So. And then antibiotics. Why would we potentially need antibiotics? Well, infection caused them to get here potentially, right? Appendicitis or something like that, or pneumonia. So potentially you would do plus or minus antibiotics if that's what's got them in here. And then once they're stable, then you would take them off the IV drip of insulin and transition them to sub-Q. But that's over time. This is like they're in the ER for a really long time, okay? So here's the basics of treatment. Nice cleaned up slide, summary. Now you know why we do this, but again, IV saline first. If the potassium is 3.5 or higher, what do? My potassium is 3.9. What do? Insulin, then potassium. Don't forget, they still need potassium. Because when I treat with insulin, I'm going to cause their potassium, the depletion of potassium to show up. They're going to feel that. If their potassium is 3.2, what do?
Potassium first.
Right, then insulin. Okay, perfect. Monitor. Any questions on DKA? I like it. I probably spend way more time on DKA than the hyperglycemic hyperosmolar state, or HHS. That's just more common. And you'll talk about it next semester too. So it is the second most common hyperglycemic cause of comas. You'll see it more in your type 2. It's really your little old ladies, I guess middle age, but usually little old ladies. And this is an insidious process. It doesn't happen fast. It happens over a long period of time. And these little old ladies will have some comorbidities, congestive heart failure, chronic kidney disease, and they'll be worse off too. The biggest difference is they're hyperglycemic, really hyperglycemic. You guys will be impressed by the sugar levels, but they're not the absence of acidosis. Okay, so they don't have ketoacidosis. So do you think they're going to have the Kussmaul's respirations? No, acetone breath, no. Why? Because those are from the ketoacidosis. Okay. High mortality rate because it just gets missed. But it gets delayed because it's insidious. It happens over time and it gets missed. Here's the pathophysiology. So there's a deficiency in insulin, but it's not as significant as with DKA, right? There's still some insulin. But in that situation, the counter-regulatory hormones jump into play, and essentially you get really, not sludge, not quite maple syrup blood, but like it's really a hyperosmolar, so really concentrated with glucose. And when it's that concentrated with glucose, it just doesn't work as well. And you don't feel well. That's why these older people don't do so great. But yeah, that it impairs kidney function. They don't feel well. Precipitating factors: infection, infarction, incision, which would be post-op, different medications that we do, and non-adherence to medicine. So I've had HHS once, and this is a picture of this guy. So he was a nurse, and he was so non-compliant, and he is type 2 diabetic. When I first saw him, he was off all his meds. We got him back on all his meds. He was hypertension, hyperlipidemia, all the things, right? And he's doing really good, and then he came and saw me, and he's like, I'm off all my meds. And his A1C was like, I don't know, 6.8 to 7, I don't know, it was good. And it had never been that good. And he's like, yeah, I'm off all my meds, I'm exercising, go figure, I'm drinking water, okay, those are good. So he's doing all these lifestyle stuff, right? And then he's like, I'm taking cat's claw. So this is what cat's claw is. And he was like, yeah, cat's claw cured my diabetes. And I was like, oh, or maybe it's the lifestyle stuff and all the things, but oh, okay, sure. So I saw him again 3 months later, and he's still doing pretty decent on his cat's claw. And then he called, he didn't feel well, and we did labs, and his blood glucose was so crazy high. I don't remember it. His electrolytes weren't crazy off, like DKA, but immediately I was like, oh my god, this guy's DKA. But he wasn't acidotic or anything like that, but he had. So, anyway, there's lots of weird things out there that can cure diabetes. Okay, so HHS, so insidious, it happens over days or weeks. Weakness, polyuria, polydipsia, super dehydrated. These people need a lot of fluids. It's actually, sometimes that's all they need is fluids, because technically their body has insulin, unlike with type 1s. But they get confused, convulsions, all of that stuff. So physical exam will make sense. What physical exam findings would indicate dehydration? Turgor. What about their mouth? Yeah. Look at their moist mucous membranes, blood pressure, things like that, right? But again, absence of Kussmaul's respirations, absence of the ketosis. So you'll be able to tell if I give, say, on a patient, a scenario, HHS versus DKA would be different for various reasons, right? Type 1, type 2, age, comorbidities, and physical exam. Okay, severe hyperglycemia, 600 to 2,400. That's high. That's sludgy, right? That's maple syrup blood for sure. And things don't work as well when there's that much glucose, that like serum hyperosmolality for sure. Like it's usually like 320 or something, which is really high. No ketosis. Acidosis is absent or not there, but they'll have some kidney issues for sure. See the difference from DKA? Treatment is very overlaps. Fluids, insulin, and potassium. Again, we're monitoring these people for a long period of time, right? We want to make sure what we treat works. And again, the therapeutic goal is to restore plasma volume, tissue perfusion. Eventually, obviously, we want to treat the glucose for sure, but we're less concerned about the acidosis because they don't have it. So, fluid replacement, underline, very important. Sometimes this is all they need. So again, we're starting IV fluids, and we are getting labs. We don't want to treat them with fluids too much, too fast. And then we also don't want their blood glucose to drop. If it went from 800 to 100, that would be really bad. Okay, so if it starts dropping too low, we may add some glucose, some D5, again to prevent the cerebral edema, hypoglycemia, or DK, rebound ketoacidosis. Insulin only if their blood glucose stays high after the fluid replacement. Okay, so again, cornerstone for HHS is what? Probably, is fluids, maybe a little bit of insulin, and then take a look. And potassium too. You'll likely need it, but not as much because of the acidosis. So the acidosis is a huge impact with DKA in treatment. Here's a summary slide if that helps. Okay, so that's it for acute stuff. I'm going to talk maybe a few slides and then we'll take a break in about 6 minutes. Microvascular and macrovascular diseases. This is someone that can impact type 1 and type 2. We just have more type 2 diabetics, right? So, end-stage kidney disease is a huge problem for our diabetics. Also, vision changes, neuropathy, and the major cause of death for type 1 is renal. Versus type 2, they can also have kidney issues, right? 15 to 20%. And there's more type 2, so we're probably going to see more kidney disease with their type 2s. But they have eye vision issues, neuropathy, but their major cause of death is MI. MI even more than stroke. Okay, why do you think it's cardiovascular for type 2?
Potassium.
Was that?
Something to do with the potassium?
Nope, this is just general complications, not acute, so we're in chronic complications. Yeah, what does my type 2 look like? They have hypertension, hyperlipidemia, right, OSA, maybe some obesity, maybe not because of GLP-1s or something like that, but right, so major cause of death, all those comorbidities is cardiovascular. Okay, so these are the breakouts that we're going to do for chronic complications. We'll talk about the eye first because I'm not an ophthalmologist. I'm not an optometrist. I breeze over these really quick. But this is going to be like honestly one of the first things your patients deal with is the retinopathy. Leading cause of vision loss amongst 25 to 74-year-olds. Pretty good, yeah. And again, it impacts both type 1 and type 2. I don't care about the percentages, but just know it's a thing and it's something that you're going to have to screen for. And the lens itself really likes sugar. So when you have someone with diabetes, they might have blurry vision, and when you fix their blood glucose, you might fix the blurry vision. But we still need to screen them and evaluate them for this. So does this look familiar? This is last semester, not a few weeks ago, right? So this is your diabetic retinopathy. There's non-proliferative and proliferative. The mild, moderate, severe, that's determined by not you. That's your eye doctor, so your ophthalmologist. They're going to decide the severity because they have all their fancy tools. But essentially, you have leaky capillaries, you have the proteins, all of these things, microvascular changes, so the narrowing, retinal swelling, not good. Does anybody want to guess what the red arrow is going to be? Yeah, I like cotton wool spots. So the cotton wools are going to be the black arrow. The black arrow, so those little white ones are cotton wool. A hemorrhage, yeah. So like the hemorrhage is the red arrow. That's supposedly a hemorrhage. Or microaneurysms is my qualified opinion. No, just kidding. And then what about the yellow arrow? Yeah, that's like exudates. Perfect. You guys are ready for this test. I'm just kidding. I'm not going to throw that up there. And then probably this guy definitely has Nikki, which I can't see. But and then you have proliferative. I think this is pretty. So if you're looking at someone's eye and you're like, oh, that's kind of pretty, that's probably a problem. But it starts with ischemia, right? So I lose blood flow, and so my body's like, I can fix that. I'm going to create more capillaries. The growth of new capillaries causes a problem, right? You also get some fibrous tissue created, and then this stuff extends into the vitreous chamber, the optic nerve is impacted. It's just not good. Less common, thankfully, but part of diabetic retinopathy. So how do we treat this? Glycemic control. We need to manage their blood pressure, their blood glucose. With all these complications, if I can control their blood glucose, I can really help prevent or stop these issues. We're going to screen, and if we haven't told them to stop smoking, we're going to tell them to stop smoking and manage their blood pressure. The eye doctors have some special things that they do too. But what do? We're going to manage their blood glucose and screen them. So you have your normal, non-proliferative with your exudates, exudates, a lot of exudates. And then you have your proliferative. If I have a diabetic who has sudden vision loss, you're going right away to the eye doctor. But if you see proliferative, even non-proliferative, I'd probably just call them. We'll go over the diabetes screening guidelines towards the end. Diabetics are at risk for cataracts as well. So it's usually gradual blurred vision with this, the opacities, crystalline stuff on the lens. Again, more with uncontrolled diabetics. So diabetics may still ultimately get cataracts even if they're controlled, but if they're uncontrolled, they're going to get it earlier. Okay. And then glaucoma. Okay. So, what do I care most about? The diabetic retinopathy, right? And controlling the glucose. So how do we need to just make sure we're screening as PCMs, that you're screening, you're asking the eye symptoms. So I have 15, 20 minutes with the patient, so I'm going to use my technician. My technician is going to help ask these eye stuff and feet questions when they get their vitals. So you want to just see if there's any vision changes and be specific, give them examples, especially if they're new diabetic. And then key to treatment obviously is glucose, blood glucose management, and then referrals. So type 1 diabetic in red, it says initial examination by an eye doctor, ophthalmologist, not optometrist, ophthalmologist, is 5 years after diagnosis, okay? Then annually after that. So how old are my type 1 diabetics again? Like, so a 10-year-old, so their first eye doctor will be at 15, right? But type 2, it's you get diagnosed with type 2 diabetes today with my A1C and my fasting blood glucose that's high. I'm giving them a referral that day, and then they go annually, right? Okay, because they're older, they're more at risk for retinopathy as well. Okay, any questions on that? We'll take a break for 10-ish minutes, and I'll see you back. Like the retinopathy is that first thing that's gonna happen. Next is the kidney nephropathy. Diabetic nephropathy is the most common of end-stage kidney disease, and makes up diabetics make up 1/3 of end-stage kidney disease patients. So I always thought the kidney was is like kind of underrated, right? The heart gets all the attention. But when kidneys fail, it's a really bad thing. Kidneys are pretty confusing, especially the nephrology part. So I'm going to keep it really simple. But one thing you need to know is the initial sign that you have diabetic nephropathy is you're going to see albumin in the urine. So think back, we have a UA. What does a UA check for? It checks for what? Ketones and glucose. What else? The specific gravity, right? It's going to tell me, like, is it concentrated or not? It's going to look, if it's clear, like usually appearance, is it clear, is it dark? An infection, so UTI, so urinary tract infection, will have different findings that go to it. It doesn't specifically test for albumin, so you have to do a specific lab for our diabetics to screen for albumin in the urine, because that's how it's going to present. You're going to have albumin in the urine. And then after that happens, and if it continues for a long, you're going to have kidney function issues, and then creatinine is going to go up. Okay, so microalbuminuria is the key factor here. Yeah.
Wouldn't albumin affect the specific gravity though?
Not specific enough for it to say.
Okay.
Yeah. So we screen with a very specific test. So you can do a morning urine, and it's the albumin to creatinine ratio, or ACR, is the assay of the gold standard, or that you're going to do for your diabetics. There's your ranges that you don't have to memorize. I will tell you, obviously normal is less than 30, and then it goes up from there. So if I have somebody who has an elevated ACR, albumin to creatinine ratio, I need to confirm it at least a couple times just to be sure, and over 3 to 6 month time span. And then where am I sending these patients? If they have, I manage their diabetic, right? You'll manage their diabetes, especially if they're type 2. Well, where am I sending them?
Nephrology?
Nephrology, yeah, you're sending them to nephrology. What do you think, if I have a kidney issue, I know you guys haven't had GU, so I'll probably just say, so treatment for microalbuminuria is strict glycemic control, just like the eye, okay? We want to manage their blood glucose with our medications that we talked about yesterday. Specifically, SGLT2 inhibitors and even GLP-1s can help with patients with this, with diabetic neuropathy, okay? ACE inhibitors, absolutely, because of the hypertension. The cornerstone treatment for people with chronic kidney disease, when we get into 3A and 3B level, is blood pressure management. Okay, so we need to manage that with our ACE or ARBs. okay? With the diabetes guidelines, it doesn't say ACE first, then ARB, it says ACE or ARB, okay? And benefit for high blood pressure, for diabetes, what do we use first? ACE or ARB, okay? So it treats both. And then nephrology. Any questions on that? We're tying in some of the stuff we talked about yesterday with the medication. Here's a guideline that if you forget, there's tools that you can help, and we'll talk about this tomorrow. But again, independent of the blood glucose goals, if I have a person with chronic kidney disease, as long as their GFR is over 30, I can use an SGLT2 or GLP-1 before metformin, or if they're already on metformin in addition, because this is going to help treat the underlying complications of the diabetic nephropathy, okay? This is a trial that was done last year. It's called the FLOW trial, and it looked at somebody who was diagnosed with diabetic nephropathy, and then they either gave them placebo or GLP-1s, and they showed that when the patients who got the GLP-1s, they had more renal protection, okay? I believe they actually stopped this study because of the impact to those with the placebo, right? So, again, so this, I can't remember if it's like, this is on all the guidelines or not, but again, not just SGLT2s, but the GLP-1s can help, are renal protective as well. But maybe more studies are usually coming at that. So as it progresses, we don't treat this, we don't screen them with the ACR, and we miss it. They obviously have nephrotic syndrome. Their cardiovascular disease risk is intensified, right? Because the kidney is an important part of that. We might end up on dialysis and things like that, okay? So just know that it progresses. You don't need to memorize the details of this stuff. And understand back here how we manage it, okay? The treatment and the labs. So we have screening guidelines for microalbuminuria. I'll say it slow right there. Type 1, same with the eye. We start to screen with this lab 5 years after diagnosis. So I was diagnosed at 10, I'm going to start labs at 15. But for our type 2, it's at the time of diagnosis and every year after that, okay? Luckily, it's very similar. And what lab do we do again? Albumin creatinine ratio, ACR. Good. That's it for nephropathy. Neuropathy. So you guys talked about neuropathy in neuro, and we did the test. So I know some of this will be familiar. Likely the distal symmetric polyneuropathy, which is the most common, but we'll talk about the all three of these here. So this distal symmetric polynephropathy, most common cause of diabetic neuropathy, and it's that glove and stocking distribution, right? So it's going to be bilateral feet. Is typically what's going on. It affects the axonal neuropathic, especially in the feet. And it's bilateral, symmetric. They'll have loss of proprioception, sometimes loss of pain and temperature. But on the other side, you might have pain and irritation. So these patients present very differently. Either they don't feel a thing and they're fine, or they're irritated. It's like, and neuropathy pain isn't like a bruise pain or fracture pain. It's very irritating, and again, it can range from mild to very severe. So when we think of neuropathy, we think of kind of like internal stuff, but it also impacts, it correlates to cardiovascular disease and foot problems. So it matters, right? Even if your patient has like not minimal pain, but they have some polyneuropathy, we still need to manage that, because if it's left untreated, or if they're a non-compliant patient who doesn't come in, it can cause some issues, right? So denervation of the foot muscles will lead to crawling of the toes, displacement of the metatarsal fat pads. You don't feel pain, so maybe you grow a callus and you have reoccurrent repetitive stress on the skin, and you get an ulcer. And then that's not so good, right? Thoughts on this? Thoughts on these feet? Not good, right? So this on a diabetic is really, really scary. This, we see the ulcer here, but all of this stuff is not good. We'll talk about these spots later. Charcot joint, arthropathy. Are you talking about Charcot?
Ortho, yes.
Yay, one overlap. Okay, so this is usually, it's not super common, but you've had diabetes for 10 plus years, you have neuropathy, autonomic neuropathy, traumas, all of these things, and over time, you will get this rocker bottom deformity if stuff is left untreated. And then obviously, this is normal versus Charcot, but very different, right? Very, very different. Osteoclastic, yeah, no good. All right, so what do you see on the patient, on the foot on the left? He's not looking underneath, so what do you see? Visual appearance, go. Rocker, yeah, the rocker bottom, the deformity. What else?
Redness, erythema.
Yeah, there's some erythema. Maybe the skin is peeling. Is that like a fungal thing? Do you want to look at the bottom of that foot, the back of the foot? You want to inspect the whole foot. You wouldn't miss that, but what you could miss that if what? If you don't have the patient take their shoes off, right? No shirt, no shoes, no oski, right? That's what I tell in ClinCore. And then same with diabetics, shoes are off. Even if it's your tech, you have a good tech who looks at it, but shoes off. You don't want to miss this because this is gradual. This poor person, this happened over 10 plus years of stuff. And then what about the one on the right? What do you guys think of that?
More mild, but still bad.
Yeah, so just the skin appearance is yellow. There's an ulcer. What about his ankle? Yeah, do you see how thick that ankle is? Look at that. Is that a good sign? Yeah, that's not good, right? But if I didn't look at the bottom of this guy's foot, they're not the same people. But let's say they are, and we look what we would miss. That beautiful guy there. But again, it's like red, it's broken down yellow, all the things. Okay. So not just neuropathy, it correlates to the Charcot. Okay. So how do we treat this? Obviously prevention, early detection. So we're going to examine the feet. We're going to at least visually look at the feet every time. We're going to ask questions. And then we want to manage, we want to treat by glucose control. So same with nephropathy and retinopathy, we're managing the glucose. We know how to do that from yesterday. But in addition to their diabetes management, we may need to add TCAs, okay? Tricyclic antidepressants are first line, so nortriptyline or amitriptyline, a low dose at night, can help with the neuropathy. If that doesn't work, then you can go to your gabapentin, your pregabalin. So gabapentin is cheaper, so you do that one first. If that doesn't work, then you go to the Lyrica or pregabalin. Duloxetine works. I've used that on people with neuropathy that failed TCAs. But again, just know first line's TCAs, and then if they fail that, you have other options. You even have topical options too. Capsaicin is what? It's in what? The hot peppers, right? And it can help. Weird burns. Don't touch your face after. I see what educate them on that. Okay, so that's it for distal symmetric polyneuropathy, right? Bilateral symmetric feet changes. Treat with TCAs and blood glucose management. This one you might not have heard of in neuro. It's less common, and it's isolated peripheral neuropathy. So already it's a different word. It's isolated either to one nerve or like a mononeuropathy multiplex. Anyway, okay. So and it's related to ischemia and or traumatic damage. But the cool thing, it's acutely presents, but it's often reversible, which is cool. And there's lots of nerves in the body, but this typically happens to the femoral and cranial nerves. Okay. So if it's happening to the femoral, I might have weakness, atrophy, or pain in my anterior thigh. And then if it's a cranial nerve, you want to do EOMs but specifically cranial nerve 3, 4, and 5, or sorry, 3, 4, and 6 are affected. Luckily, it gets better with time. Let's test this. Okay, cranial nerve 3 palsy. Let's test. So, which one is abnormal? Right or left?
Right. The right.
And for most right? Okay, why? Because I said, all right, I'm going to tell him, look to the left. Or, well, sorry, look to his right, so he looks to the right, okay? Look up. This one goes up. No. Look down. No. So, yeah, it's the right side. So that's an example of isolated peripheral neuropathy. Okay. The last one under diabetic neuropathy is autonomic, right? So this is someone who's had diabetes for a long period of time. Maybe they were controlled for a little while, or they thought they were controlled at 7.5, and they were at 7.5 A1C for years and years. They're going to be at risk for autonomic neuropathy, specifically GI, GU, and our blood pressure. So GI, gastroparesis, we talked about this in our side effects for GLP-1, right? We're slowing down GI emptying. And that's a significant problem for people with diabetes. So caution if you add GLP-1s to these patients. You can treat with Reglan, you just can't use it for too long. Use that medicine for nausea. Gastric, this is totally FYI. Gastric electrical stimulation. So you guys know, have you ever heard of that? They think of like a pacemaker for the GI tract. I'm probably oversimplifying it, but that's kind of cool. So that's an option. Constipation is common in these patients, and then you can also have the opposite where you have diarrhea, incontinence, and it's related to the nerves of the rectum, right? That impaired sphincter control, so that's why they'll have fecal incontinence. And it's not a back issue; it's a nerve issue in the sphincter. Okay. So GU, incomplete emptying of the bladder, common in diabetics. Probably most common is ED, or erectile dysfunction. Erectile dysfunction can be a neurologic, right? Autonomic neuropathy, physiologic, or the psychologic, right? Performance anxiety, and then vascular. So ED hits, there's 3 causes potentially. And this one is more the autonomic nervous system. And how do we treat that? Whether PDE5s, and phosphodiesterase, type 5, so your Viagra, or sildenafil, or any of those drug classes. If you have a urology rotation in phase 2, they do all these other things. They'll do implants and vacuums and surgery, all in your MTF for male patients with erectile dysfunction. Right? And then the last one is the orthostatic hypotension. So we can treat that with like stockings. People like to wear stockings, but maybe you tilt the bed, slow to change positions, or there's medications. That's it for neuropathy. Next is cardiovascular. This is going to be review, okay? Because you guys know all this stuff. MI, myocardial infarction, so a heart attack, leading cause of death in our type 2 diabetics, right? Our females with diabetes, they lose that protective, not shield, but the protective advantage that females have from just having more estrogen than males. Once they're diagnosed with diabetes, they lose that protection, so they're at an increased risk for a heart attack versus someone without diabetes. 3 to 5 times higher incidence in your diabetic patients. That's significant. And there's your why, all of the things that are associated. There are also increased risk of strokes and TIAs, but again, MIs are the most common. Hypertension. This should make sense. We really want to control blood pressure, and we want to control it really tightly, right? There's depending on which source you read, there's the value options for diabetics. But again, what do we treat our diabetics with for hypertension? What's our first line? Blood pressure. ACE-RR, right? Yeah. Peripheral vascular disease, so that's ischemia in the lower extremities. and it leads to peripheral arterial disease. So poor flow eventually is poor healing. So that's a problem for our diabetics, right? Why? Because they don't feel when they step on something. They don't feel their callus that they're creating. Then, so I have neuropathy, I don't feel it. Then I have poor flow, blood flow. So it decreases my chance of healing when my callus turns into an ulcer. So you see how it overlaps. We talked about erectile dysfunction and peripheral vascular disease. And then there's gangrene and intestinal angina as well. That's like where you have some, don't worry about that so much, but it's so specific. But a patient would present with like severe abdominal pain, like out of proportion abdominal pain. It's just like the blood flow is lost in the intestine. Bad day. What do you see in this picture of this male or female's foot? I know orthosphragis maybe, so not so much the bones. What else do you see outside the bones?
Looks like calcified veins or arteries.
Yeah, look at those arteries, right? Or this vasculature. Look at this vasculature. Pretty significant. So this person has peripheral arterial disease. Again, it's not like I'm using an x-ray to diagnose this, but a lot of times you'll order an x-ray and they might report some of that to you. And then guess what? You're the PCM. You need to do something about it. Again, PAD plus neuropathy is bad. So we already hit this, blood pressure, ACE/R. For cholesterol, you don't need to memorize the values, but we use statins, and the guidelines for hyperlipidemia are really strict for our diabetes. Okay, they're stricter than the general population. So when you go out there and you treat your diabetics, you need to be very aware of the lipid goals and their risk. Okay, may consider aspirin for some of these patients, depending on their age and risk factor. Obviously, cornerstone is healthy lifestyle, diet, exercise, sleep. And then, are they still smoking? Talk to them about that. Spend a second to get them to quit. Okay. Any questions on cardiovascular complications? Fairly good. Makes sense. And then we're going to talk a little bit more about the foot stuff. So we go neuropathy, peripheral arterial disease, and then so we have the ischemia, the neuropathy, and then we get an infection, right? Because they don't feel it. This is not good. You need to refer, and these people don't do well. So this patient. So look at her foot. Okay. So we don't have look. Okay. So you see that guy's ankles. He kind of looks like something's going on. Ignore the toe. But if you take the toe out, it looks like a normal person's foot, right? Like, especially compared to that man with the shark coat, right? So this woman, she's diabetes, we'll say pretty well controlled overall. She had an ingrown toenail that her PCM removed. It didn't heal. It didn't heal for months and months, 6 months, and they finally sent it to the podiatrist. They were just throwing antibiotics at it, and this is what happened. So, remember with your diabetics, a callus, ingrown toenail, it's fun to do procedures, it breaks up my day when I get to do them, but with your diabetics, be cautious, especially lower extremity toenail stuff. Yeah?
So with an ingrown toenail though, so when would you judge the risk of like healing with a procedure versus like the chance of infection because of like...
I would send them to podiatry.
Okay.
Yeah, so I like doing procedures in ingrown toenails. Unless if it's a non-diabetic and they've had a bunch of ingrown toenails, I might refer, but I would send them to the foot specialist.
Okay.
Yeah, and then I would manage their glycemic control. There are non-procedural ways to treat ingrown toenail, and I always do that for everybody, even if they're waiting for an appointment. They're silly, they're really silly, but they work. So I would do that. So gangrene, we talked about this with the cardiovascular complications. This is a picture of dry gangrene. Bad, right? Bad day. What do you think, how would wet gangrene be different? This is dry, it's flaky, black, dead skin. What would wet gangrene look like? Yeah, it would be like wet, obviously. It would be like oozing, infection, draining, the odor. There would be an odor. for sure, maybe not so much with this one. So again, neuropathy, PAD, ischemia, repetitive trauma, we get the ulcer infection and then amputation. All right, so we're PCMs, what do we do? Well, we need to look at their feet. And I don't care which foot exam chart you use, but you're gonna do a monofilament test. Your technician was trained to do this, and they're gonna document any changes. Once a year, you're gonna do this. But every visit, no shoes, no shirt, no oski, no shoes, no diabetes visit. Even if your diabetic comes in for back pain, just have them slip their shoes off, and so you can, your tech or somebody can glance at their feet, or you. Here's the link to monofilament. Again, it's just checking all the different areas. You do have to change the monofilament attachment regularly. But again, it's just assessing, and we're trying to catch this early. So we're looking at their nails, calluses, deformities, watching them walk, right? We're looking at the bottom of their feet, not just the top, checking pulses, checking deep tendon reflexes, all of that, and an annual monofilament. And again, remember, see that little callus? You guys might not worry, he also has, his nail, there's a fungal infection on his nail. Again, it's the fungal infection can get anybody, but especially diabetics, but his callus, you need to be aware, right? A simple callus is not simple for diabetics. So we have our podiatrists that can help us, especially if they're starting to develop any kind of weird skin changes, and then teach the patient. You see, I like this, such a simple picture, but like, would you have thought of that? Grab a mirror, because maybe you're elderly, or maybe I have a big belly and I can't look at the bottom of my feet, or I have an injury. Use a mirror. Teach, there's guides and stuff that you can teach them to dry their feet because of fungal infections and skin infections, and wear shoes. Okay, so diabetics should obviously wear shoes and not be barefoot. Why does it matter? I've added this is from 2017. I think it was last updated in 2023. So this is 5-year mortality percentage. So essentially, patients who develop, diabetic patients who develop a foot ulcer don't do well over the next 5 years, right? So we have shortcuts here, diabetic foot ulcer, then that leads to an amputation, just a little toe amputation, but 50% mortality in 5 years. A full limb amputation, so like the ankle or knee below, they have what, 50, I guess not that much more, 60, right? So really significant. I was in that trauma TDY I went to, this was the trauma surgeon, and we removed the guy who's, he had an amputation below his knee, and we did the amputation and it included the whole knee joint. And it was super cool. It's super cool because I don't have to chart or do anything. I just get to go in the OR and help. But I asked the trauma surgeon, I was like, hey, is this guy diabetic? She's not. I'm just removing the leg. I was like, oh, okay. So trauma care about the surgery and that stuff. But again, it was definitely, we looked it up, it was diabetic. Your active duty aren't going to be these amputees, but your retirees can be these amputees, okay? So it's really important to educate. Yeah, it's not all just like homeless and underserved populations that get this. Diabetes, it can be very overwhelming. And so people aren't compliant with meds, and it becomes a problem. You guys old enough to know what DARE is? Yeah, so did DARE work? Do they keep us off there? Yeah, same like, just like with STDs, we can't like show kids like, here is gonorrhea, don't ever have sex. Like, does that fear work? Probably not, maybe for some. Same with your diabetics. You can show them these gross pictures of feet, but ultimately it doesn't necessarily work. So, but building that relationship, identifying that diabetes is overwhelming, and that you're there to help them. Okay. Last section of complications is skin and bone. Again, remember for my test, this isn't derm, so I won't show a picture and be like, what is this? It'll be part of the story, okay, part of the clinical presentation. So our type 1 diabetics or type 2 who use insulin and don't change the spots, they have a risk of atrophy or lipohypertrophy. And those pictures of both. So remember that little cartoon character with that little guy and his little, with all those little poke marks? This is why you adjust where you give the insulin. So again, it's a fatty tissue buildup or atrophy. Their risk for skin infections. This is type 1 and type 2, right? A lot of times the type 2 patients will have reoccurrent skin infections, fungal infections, and things like that before they're diagnosed. So you see, it's the nails of these. So that's what a fungal nail infection looks like. Technically, it could be other stuff too. So you want to sample it and send it to the lab before you treat it, because oral antifungals are a doozy on your liver, and topicals don't work as fast. So we talked about the picture below with the eruptive exanthem when we talked about possible presentations for type 2. But that's what those look like, and they're related to high triglycerides. Same, so at the top you guys learned about exalthemas under the eyes. That's usually associated with high triglycerides. I think I've only seen it once, and it was not an active duty. It wasn't in the military. I was really excited, but unfortunately these don't always go away. They can be permanent. The exalthemas can. So necrobiosis, oh gosh, lipidica, diabeticorum. So type 1 diabetics, you get these like bilateral, they're kind of symmetrical, yellow, papular, more like plaques, right? Or like plaques on your lower legs. But you can, they have demarcated borders. You know that this needs that much because we haven't had dirt yet, but you see their vessels. So you have these borders, they're symmetrical, and you see those vessels. Yeah, that's what that is. So we treat with steroids and glycemic control. Hey, you guys know what these are? Dupuytren's contracture, right? Diabetics can often have these. Carpal tunnel syndrome as well. I don't have a picture of carpal tunnel, but that is another thing that you can screen for. Okay, so that's it for complications. We're going to go through guidelines. These are testable things that you, for the testing for life. And we'll go through a lot of these. We've already talked about vitals, important. We talked about looking at the feet. We talked about the lifestyle stuff. So we'll dive into just a summary of the things. So screening labs. A1C every 3 months, right? That makes sense, right? Because we need to give 3 months to see if the meds work, and then that 3 months allows a change in the A1C, because the A1C looks over the last 3 months. You can't, if you have a super well-controlled patient, you can switch it to seeing them every 6 months. But typically, you get to know your diabetic really well because you see them every 3 months. And then for other things too. Goals individualized, but ideally, where do we want their A1C? Less than or equal to what? 6.5. Why? Microvascular changes, right? We want to prevent it. But yeah, ideally less than or equal to 6.5, 6.5 to 7. We're aiming for 6.5. But if they're older, they have a polypharmacy, so they're on lots of meds, or have a hypoglycemic risk or things like that, maybe that range will be a little bit higher. But again, we diagnose them with the A1C and we use the A1C for screening every 3 months. Once a year, they need a CMP for liver and kidney function, right? We need to check that once a year. Because again, it overlaps with their hypertension risk. Cholesterol, they need that every year, and we're going to treat it aggressively. And then how often do we need that microalbumin screening? Once a year for type 2 diabetics. And then after 5 years from diagnosis, and then once a year for type 1, right? And it's the albumin-creatinine ratio, or ACR, annually. Here's the table here for the person. Okay. Treatment is independent of the glycemic target. We'll talk about this a lot tomorrow. So essentially, yeah, that one we'll talk, just write out like a thing, right, diabetes lab. So I'll hit that tomorrow. Meds to initiate are considered in our diabetics. So again, ACE or ARB for hypertension, right? ACE or ARB for microalbuminuria. We talked about maybe an aspirin for the cardiovascular contraindications. Not everyone who's diabetic is on an aspirin, right? But you would consider it. Obesity meds, so we have our GLP-1s, but if for some reason they can't be on GLP-1s, maybe you do phentermine or things like that. Cholesterol, they need their glucometer and their strips. And then obviously type 1, they need that bracelet, tattoo, necklace, something that says I am type 1 diabetic. They need more vaccines. I'm not going to quiz you on this, but you need to know that they need more vaccines. They need their pneumococcal influenza, shingles vaccine. These patients are at risk. They need this. I highly recommend these. And I actually, so I don't forget, because diabetes is a lot, right? I have an autocorrect, and in my autocorrect, in my assessment plan, it says vaccine, so that I remember, like, hey, do your flu shot. Hey, have you got your pneumococcal? And then, should these guys be smoking? No, it's been like, I don't know, it's the 10th time I've talked about tobacco cessation. No. And then we have referrals next. So certified diabetes educators are your RNs. If you don't have them in clinic, you can refer. And then they just sit down and talk with them, and they'll go through lots of things with your diabetics. They have more time that unfortunately you don't, at least how clinics are set up. Endocrinologists for all type 1s, or you just have that uncontrolled type 2. You're throwing all the meds at it. You start, I don't necessarily, if I start them on basal insulin, I don't necessarily send them immediately to endo. I give them 3 to 6 months on that first. But if I'm starting to think about bolus insulin, I endo, okay, for a type 2. Referrals, you guys already know this. Ophthalmologist referred 5 years after diagnosis is made for type 1, and then annually for type 2. We have a podiatrist or a vascular surgeon if we worry about some PAD, so peripheral arterial disease, and neuropathy, structural problems. We got ortho. Nephrologists for any kinds of diabetic nephropathy, so remember that ACR. We have websites. There's lots of education out there for people. These are good ones. There's some not so good ones, I'm sure, out there, like the cat's claw guy, whatever. So again, there are in the guidance for diabetes, there's specific stuff for hyperlipidemia, hypertension. It doesn't go in depth like you did with Dr. DeVore, but they're different than just the general population. And that's it for complications. So we're done with the new material. I'm not teaching tomorrow, colitis, we swapped. And then on Thursday we'll do our diabetes lab and its participation. And we're really gonna iron down treatment. And you guys get to decide, raise your hands, vote, if you're gonna do meds, if you're gonna do this, okay? So it kind of solidifies everything. And then next week will be all things antigens. So we'll see you Thursday.